we don't have a push towards research in reproductive health specifically. So there's a bias towards women, and even just the way we are treated, the way we experience medical care, the research that goes around women's health, and that takes longer to diagnose if there's going to be such a huge bias.
When it comes to pain management, doctors, we have it all wrong. Or healthcare providers, we have it all wrong. Because many people really complain that we don't really address their pains.
Yeah. I would be dismissed, especially by doctors, because it's like, you're here because of your period, it's one thing when you hear it from other people.
The lungs, the brain, and those are the women who actually convulse every month when they have a period because they have a lesion in their brain that is endometriosis. You pain every time you pass stool. You could be having pain every time you have sex, especially if you have endo in the vagina, or if your uterus is completely adherent to the structures around it, meaning your uterus can't move freely even during sex. You have a lot of pain during sex. So it's not just period pain. Endo patients, endometriosis changes your perception of pain, which is really crazy, because the way you are mentioning about the anxiety, because you don't know what you're going to expect.
Hi guys, welcome back to A Dose of Health, the podcast where I give you not too much, not too little, but just enough information to make you make an informed decision. It's a lovely afternoon today, and I have some beautiful guests, and I'll just let them introduce themselves, and then we'll get to the topic of the day. So the floor is yours.
Thank you. My name is Vanessa Kanyaru. I wear many hats, but today I'll just introduce myself as a podcaster. I also have a podcast. It's called Oh My Mind. We talk about mental health from personal experiences and expert insights as well. And I'm also an endometriosis warrior. Yeah. That's it for me for now.
Hi everyone, how are you? Thanks so much for having me. My name is Dr. Christina Sule. I'm a consultant obstetrician and a general and cosmetic gynecologist. I am the CEO and medical director of Alora Medical Practice. It's a boutique clinic where we cater to women's health, women of all ages, from teenagehood all the way beyond menopause. What else? I'm a mom. I'm an avid traveler. And yeah, that's basically me. I love taking care of women.
Yeah.
I say the word vagina every day. Other than Sunday. Sunday is
than
the day I
Sunday.
give myself a break. But yeah, that's basically me.
And happy early birthday. So it's her
Thank
birthday
you.
soon.
Yes,
Even if people are, it's like you're not allowed to celebrate your birthday,
I'm
but happy
excited
early
about
birthday.
this one. Yeah, I'm turning 39.
Wow.
I'm so old.
You don't look like it.
Really?
Question. Are you looking forward to 40?
I am.
Okay.
I am. I'm
Yeah.
not scared of it. I'll
Yeah.
face the monster. Yeah.
Okay. Karibu sana, guys.
you.
Hey, your bios, I'm just like, ish. All right. First of all, this is just a shameless mention. She was my lecturer, so it's so nice to have you.
Wow.
You don't remember?
Oh,
Doc, you don't remember?
listen, I've taught so many
Yeah.
people. Like I get that a lot from like clients and from students.
Yeah.
But was I a good lecturer?
Yeah.
Oh, thank
The two of you, there was you and then there was Dr. Bosire.
Oh, nice.
Yeah.
Oh, that's amazing.
So
Yay.
it's really nice to have you guys here.
Thank
So
you.
before we get to like the intricacies of the topic, I just want to find out, how are you guys doing emotionally? So I usually do a journey to Inside Out. Have you guys watched Inside Out?
Yes.
Oh, thank God.
Yeah, the
you need to go and
animation,
watch
right?
it. Yes, the animation.
Yeah, my daughter
You need to
forced
go and
me.
watch it.
Me too.
It's
Yeah.
really nice.
Yeah, both.
Yeah, 1 and 2.
Yeah.
Good. So where are you guys emotionally?
I'd say mixed feelings.
Okay.
Right now. Part of me is like happy and content, but the state of the nation right now is just making me very anxious, and I'm just very antsy, and yeah, it's not looking good.
Yeah.
I'd say some.
We filmed 3 episodes today, and this is the second time it's coming up. So
Yeah.
true.
Mm-hmm.
Okay, what about you, Doug?
Yeah. Honestly, not a great day for me. A really difficult surgery, but also at the same time, yeah, I'm gonna agree with the state of the nation. June is my birthday month, and I feel like that's been eliminated.
Yeah.
I'm feeling very, and I hope this doesn't sound selfish, but I feel like I've not had the liberty to celebrate my birthday, last year and also this year, and rightfully so. I'm not bitter about it, but I'm just like, yeah, I think it's one of those things I'm slowly going to start to shelve, because 25th of June is something that we can no longer ignore.
That's true.
And that's
true.
fine. But yeah, not great.
Okay.
But yeah, here to power through.
Yeah. I think for me, what did I say? First of all, I'm in the luteal phase, so there's that. But I am I would say happy. Yeah.
Oh.
I would say happy because it's the last episode of the day.
Ah,
Yeah, and the persons have been exciting.
Good.
Yes,
Can't
yeah.
wait
So
to
I'm
watch.
happy to have you guys here.
thank you.
Okay, so now medical jargon. Is there anything, so for Vanessa, is there anything that you want us to debunk for you? Or is there anything you want to debunk in relation to health? And then Doc the same. Maybe people keep getting this term wrong or they don't seem to understand this particular term. Or you just want to elaborate it. Yeah.
Anything, or does it have to be related to?
To health, not the
To-
topic
to-
of
oh.
the day, but to health in general.
Oh, wow. That one, that hyper...
Oh, hyperglycemia.
That one.
Ah.
That one. Yes.
High blood sugar.
Ah, okay.
Yeah.
Yeah.
Your sugar is above the normal range.
Okay, yeah.
Yes.
I heard it being thrown around, so I was just like, oh, what is that? Yeah.
So maybe let me give Doc a backstory.
Mhm.
So we like teaching as doctors, and here on this set, you always learn something new. So George, who's behind the camera, was saying, I don't think it was this podcast. I think it was a different podcast. He also learned the word hyperglycemia, and now he's been throwing it around. Let me I know things. Yeah. And let's add hypoglycemia is now low sugar. So hyperglycemia, hypoglycemia.
Okay.
Yeah.
All right. Got it. Yeah. Thank you.
Over
Yeah.
to you.
For me, I feel like, and this is just like a general mix-up.
Mhm.
People come and they're like, Doc, I have a UTI.
Mm.
And I'm like, okay, what are you feeling?
Yeah.
What are you actually feeling? And they're like, I have this weird vaginal discharge. I'm like, so we can't call that a UTI because it's like urinary tract infection
Yeah.
in the urinary tract. So you're going to have like burning sensation when you pee, wanting to pee many times. Some people have blood in urine, things like that. But like an abnormal vaginal discharge is just that. It's an abnormal vaginal discharge. It could be a whole bunch of things. Could be an STI, could be BV, could be candidiasis. And I find that mixed up many times with UTI. I think UTI is just I'm gonna say colloquial term for any kind of abnormality down there.
Yeah.
Which is really unfortunate. So
Yeah.
that's probably what I'd want to debunk
That's
today.
a good one. It's a
Yeah.
commonly asked question.
Very, yeah.
Okay. So now let's start the topic for the day. So we're here talking about endometriosis. Just because many a times when we're learning about things in relation to health, we learn it like textbook, we don't get to hear like lived experiences and just get to understand what is it like living with this condition, and also what's the treatment like, what's the process interacting with the healthcare system. So that's why we have Vanessa here today. She says she's an endometriosis warrior, so she'll give us her backstory. And then of course you have to have the professional.
Yeah.
So Vanessa,
Mhm.
how has your endometriosis journey been? Maybe you can just take us from the start,
Yeah.
how it's been for you. Yeah.
Okay. Maybe I'll give it in two phases, which was before diagnosis and after. So I started my menses when I was 12. Yeah,
You
I was
guys were
12.
early.
Yeah.
Too.
Yeah, 12.
12.
Yeah. Yeah, because I was in class 7, yeah, so I was 12. And I remember within the first few months, I had a very, very like painful period. And I think when I started, I think they're a bit irregular because we've just started. So I've not really gotten the hang of it. And I remember it was really, like, I see that image because I remember how intense it was. I was in pain. I was like literally crawling on the floor. And it hadn't registered that it's because of my period. That's why I was in that much pain. I remember even my aunt was telling me this is amoeba, and she's given me all this type of concoctions, and 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 then I took whatever she made for me and some painkillers. Then I went to sleep, and then when I woke up, I was like in a pool of blood because it was my period, and I didn't know.
At 12?
Yeah, I didn't
Wow.
know. I'm still getting the hang of it, right? And then now, I think after that, my menses have always been very painful. But then I'd just be told it's normal, latopitase V2, and then I'd be told things like when you get older, after you get pregnant, and nini itaisha, you'll be good. So I think I used to think that I'm exaggerating my pain because everyone would be like, it can't be that serious. So I think the only person who used to believe me, honestly, was my mom or my parents, basically. So every other month it's just painkillers. I go to hospital, and I'll just be given painkillers, nothing serious. So I remember instances where there'll be like it's quite painful to the point of convulsing. Sometimes And again, it was just always the same story. Either I'm being told I'm exaggerating the pain or it's not that serious. And then, and so I just continued, honestly, just learning that when I'm on my period, I just learn. I need to know how to manage the pain. There are days, of course, where I couldn't make it to school, and then now I'm into adulthood. Now I can really go to work for at least like a day or two, and then now I was like, okay, I've gotten used to. I mean, you don't really get used to the pain, but now I've gotten used to
You
living.
found a way to manage
Yeah,
it.
I found a way to
Okay.
manage it. But then now when I started noticing now there really is something wrong was, this was actually in 2020, that COVID period. So it's like the pain just got extremely worse, like it significantly worse. And it's like with every other month, it was getting worse and worse. So like the next period is just worse than the previous one. And I remember times when I'd go to the washroom and it's like blood is gushing out like a tap. It's like you just opened a tap and it's gushing out. And I was like,
Yeah.
okay, now this is a bit too, yeah. So I went to a doctor, did some scans, like an ultrasound, they saw some cysts, and then now I went to a gynecologist, and now this one was like, okay, he just saw cysts, and he was just like, PCOS, and immediately I was put on medication for PCOS.
Okay.
And so me, I was like, the doctors told me it's PCOS, and I don't know these things, so I was like, okay. And then the next period came and it was even worse than the previous ones. And I was like, Kwani, these meds are not working. And I remember that one was really bad. I had to go to hospital for like the jabs and stuff. And then now again, I was told now to see another gynecologist. And now when I saw that one, that's when they were like, actually, there's nothing you've said that we would say is actually PCOS other than the cysts. You don't have any other symptom. So I was like, okay. Then he was like, it sounds like endometriosis. I can't diagnose without proper, but it sounds like endometriosis. And I was like, yeah, right.
Did you know
Not
what it
me.
was?
At this point, I knew now what
Okay.
endometriosis was because
Okay.
I'd seen some people share their journey. I had seen and read Jambi Koikai's story as
Yeah.
well, the late, sorry.
Yeah.
So, I had an idea. But when he told me that, I was like, yeah, no, not me.
Yeah.
Can never. Because I even remember being on a call with my cousin after that, and she was like, yeah, they should really check you for endometriosis. And I was like, yeah, not me. Not me. So then now I think I was scheduled for a diagnostic laparoscopy. I hope that's what it's.
She's looking at me like I was there. She's like,
No,
"Look, I'm
I
just
hope
looking
I've
at
used
you
the
to
right
confirm."
term.
Yes, it's the right term.
Yeah. So, and then I think I was like, yeah, I was so sure they would not find anything. Yeah, because again, as I've said, it's been ingrained in me that I just usually exaggerate my pain and I have a low pain tolerance. That's how so I was sure they wouldn't find anything, but turns out I actually had stage 3 endometriosis, and it had covered the ovaries and up to the bladder as well. And yeah, so I went through the surgery to I don't say to manage that or to I don't want to use the wrong terms, but
Use
cut
whatever
the
terms you
Okay,
want.
yeah.
No, for real, use whatever terms you
is it to
want.
cut the lesions or I don't know.
Yeah.
And recovery was a whole other journey for me. And then now since then, first, I now accepted.
Yeah.
Accepted that, okay, I do have endometriosis. And then now it's just been learning what works for me, what doesn't, what triggers the pain or what makes it worse, understanding flare-ups and such, endobelly, because I used to be so tiny. So small.
I remember,
You remember?
I
I was
remember,
like
yeah.
so tiny. I was so small.
Yeah.
And so when this was now before diagnosis, and I didn't realize this is what was happening. When I'd have a flare up, I'd just think it's like bloating. It's normal bloating. So now later when I realized, oh no, it was actually, like it's called like an endobelly, and you have like a bulge and stuff. And then now after I was put on like medication and stuff, and then I really gained.
Wait.
I really
Yeah.
gained weight. And saizi nimerudi kidogo. I really gained weight. And those days now, like when I'd have a flare up in my tummy bulges, the congratulations I'd get.
Oh,
You're
yeah.
so rude.
Yeah. And
Wait.
I actually stopped posting even on Instagram for like 2 years or so, because anytime I post it on my story, on my feed, it's just always, oh, congratulations. I'm like, oh, why didn't you tell us? And I'm like,
Tell us what.
tell you what? Yeah. And I'm like, oh, you're glowing. Oh, tell us a secret. Guy, come here, people. And I'm like,
I have a question. Can I please? I have a question.
Yeah.
So I am normally the person who says the wrong thing at the wrong time.
Yeah.
And I feel like I would be one of those people, not to be rude at
Yeah.
all, but do you think tone matters? Because actually sometimes
Tone matters.
sometimes it's
does.
very innocent and like
Yeah.
you're just like, I honestly didn't know. Like, I'm so
Yeah.
sorry. Does tone matter?
I
It
feel like tone
does.
matters.
Yeah.
But at the same time, for me, I've just like learned to stop.
know.
Yeah.
Okay.
Just
Yeah.
completely because
Yeah.
Okay.
Because you
I
don't
know.
know.
and put in your mouth a bad one.
Okay. I'll learn. By the way.
Slowly.
I'm that person. Like at the wrong time, I just say something and I'm just like, honestly, you didn't need to say that. Like, let me tell you a funny story. I'm so sorry
Yeah.
to interrupt,
It's
but
okay.
I met a content creator
Mhm.
and they had traveled, and I had just watched like one of their, I think, vlogs. Yeah, one of their vlogs. And in their vlogs, they had traveled.
Mhm.
So I met her and I'm just like, are you not in like wherever you had traveled to? And I was just like, that sounds very stalkerish. Like, Hope, like, please control yourself.
But they're a content creator. They should expect people to follow them.
Yeah.
I feel like that's not wrong.
Anyway,
Yeah.
I just felt like, guy, can you just control your mouth, young girl? Anyway, sorry, go on.
So now, I mean, just back to that. Can you
Yeah.
imagine, like, okay, already, with endometriosis, there's a bit of ish when it comes to fertility, and you're not very sure.
Yeah.
And now you're here being told
Yes.
congratulations.
Okay, yeah.
And it's like,
Mm,
Yeah.
you know?
yeah.
So it's come with also a lot of mental adjustment to so many things. But I mean, I think I'd say I've learned how to work around it. Yeah, to thrive. Yeah, you can live with it. You can live with it, and I mean, you can live an almost. You can live a normal life. Let me not say
Yeah.
almost. You can, and also like I think experiences vary from person to person. But I wouldn't lie, it's been the ghetto. It has been the
Sorry
ghetto.
about that.
Yeah.
So sorry about that.
Thank you. We're good now.
I think when I first heard your story, I was like, oh my goodness. Because I realized that, you've gone off social media.
Yeah.
And I was just wondering, like, are you okay? Like, what's happening? So when I got to learn that now you've just been diagnosed with endometriosis and something that you're managing, I was like, okay, it makes sense.
Yeah.
So now let's pause on your journey over to Doc. I think of late we've been seeing more and more cases of endometriosis, and even just from her case, there was a late diagnosis. So I just wanted to find out, why is this the case? And also, what are some of the common symptoms and signs of endometriosis that maybe a woman or a young lady can actually just look out for?
So let me actually start with the signs and the symptoms,
enough.
and then so that what I'm saying makes sense.
Yeah.
So one of the most obvious things is a painful period, right? And I'm gonna be coming back to that over and over again
Okay.
because there's a lot of. I remember when I started my first period, they weren't initially painful, and of course they're irregular, and I was 12 years old, and that was fine. But then at some point they did become painful. And I remember being told, but this is part of being a woman. You know, like you can't be out here complaining about this. And even before I'd started my period, my mom would tell me, like, look, it's gonna be painful. And she went through pain, and like that's something that you should expect. So already you're conditioned that, you know what, it's gonna be painful. But the thing is, nobody tells you, how painful is that gonna be? At what point is this now unacceptable? You know, like where does the line between discomfort and other things end? And so when we're conditioned like that, then we're like, okay, I was told it was gonna be painful. Here I am. This is what I should expect. I should just, this is my portion. And so that's one of the things. Of course, you can also get irregular periods. Some women will struggle with fertility just as a symptom, like I'm unable to get pregnant and that is my symptom. And then it's later on discovered that they have, endometriosis. For me, I'd say the thing people need to look out for the most in endometriosis is pain. right?
Okay.
Sometimes you can have heavy bleeding, you can have an irregular period. Those are not the major symptoms of endo. The major thing is pain.
Okay.
Now, why does it take long for us to diagnose endometriosis? A number of reasons. The first is normalizing that pain. That's a big reason why we're not able to
Just pain.
diagnose.
Yeah.
Pain, you're a
Exaggerating.
woman, but also you're a woman. What do you expect?
Mhm.
Like
Exactly.
you want us to cry for you. It is normal to have this kind of pain, and
Yeah.
I feel like the biggest way we can start to deal with this is to stop normalizing that pain. It's like not okay to be in excruciating pain when you're in a period.
Yeah.
You can have discomfort, you can be a little bit bloated, you can feel yuck, but you should not be in excruciating pain. You should not be convulsing, you should not be
Yeah.
passing out. You need to be able to carry on your normal daily activities. When that stops, that truly is too much.
Okay.
Right? The second thing is that there's an overlap of symptoms. Fibroids also cause pain. Adenomyosis also causes pain. An ovarian cyst can cause pain.
Yeah.
So it's very difficult for even doctors and other clinicians to be able to just delineate and say this is endo because you have pain, because there's a lot of overlap of symptoms.
Yeah.
So that's another reason why it's very difficult to diagnose. The other thing is that we don't have a fairly non-invasive way of diagnosing it. The diagnosis, the definitive diagnosis for endo is a surgery. So can you imagine if you walk in and I tell you, I think you may have endo, but I can only know for sure if I operate on you.
I'm not coming back.
You're not coming
Let me
back.
take a second, third, fourth, and fifth opinion.
Yeah, for sure. You're
Yeah.
not coming back. You get. So you're definitely not, because the diagnosis is a surgery. Right now, we have a few better ways. Yeah, we have some endo specialists that are able to do a vaginal ultrasound right now, and they can, if it's an endo specialist and if it's a good vaginal ultrasound, they're able to almost exactly tell what it's gonna be like, and then the laparoscopy or the minimally invasive surgery is gonna confirm their findings. It may be a little bit worse than what they expected it to be. It may be a lot worse, but at least they can get a picture. They can say, yes, this is endo or this is adeno, you get? And so those are the people who I'm gonna be encouraging people to look for. Like, you need to have a gyna, you need to have specifically an endo specialist, and they need to be able to do that scan for you to be able to tell, because then at least you're going in knowing, yes, it's endo, maybe worse than what was seen in the scan, but at least I know it's endo, or I know it's adeno, or I know it's fibroids, or I know it's all three.
Yeah.
And then this is what I'm getting myself into. You get? Not to say that we can avoid laparoscopy. At the end of the day, if you have endo, you're very likely to have laparoscopy, depending on how bad it is, depending on the stage. You can avoid it, but it might come up in your future. So the way of diagnosing is also a hindrance in how quickly we get to diagnose. Actually, globally, it takes about 11 to 15 years on average to diagnose endometriosis. So if you're taking less than that, it's already a win. You get, it takes very long to diagnose endometriosis. We also have bias in reproductive health research. People want to research other illnesses, cancer, children's health, general health. We don't have a push towards research in reproductive health specifically. So there's a bias towards women, and even just the way we're treated, the way we experience medical care, the research that goes around women's health, and that takes longer to diagnose if there's going to be such a huge bias. So, many reasons for late diagnosis. Yeah.
Actually, two things you've mentioned that are so important, especially the research. I've been seeing there's limited research in reproductive health, but funny enough, there's a lot of advocacy. I don't know if it's just me who's
Like
noticed.
people want to talk about it more than they want to actually get the work done. Yeah,
But they need to work hand in hand.
Yeah.
Like, you can't just be doing one and ignoring the other.
For sure.
Then there's something else you mentioned. Gosh, can I remember? You said so many. Oh, yes. When it comes to diagnosis, because many times you need the laparotomy. Laparoscopy. I'm sorry. Laparotomy, cutting you.
Yeah.
So for us, like when I was in clinical practice, we honestly used to do a diagnosis of exclusion most of the time, because you've done the scan, you can't see any fibroids, there's no signs of adenomyosis, there's no cyst. So you're just like, it could be endo, but then I refer to now an actual gynecologist. And lucky enough, we had, so where I did internship, there was a gynecologist who's now an endo specialist, Dr. Njagi.
Yeah. Dr. Njagi is amazing.
He was so good. And the thing is, he's so passionate about it. But me, I was just like, honestly, these procedures are so boring. I don't know why I'm here. But just now I can tell the relevance of what he was doing.
Right.
Yeah, and he used to do it in Mashinani because it's inaccessible to many women there.
100%.
Yeah.
Yeah.
So Now, interacting with the healthcare system, how has that been for you? And I know one thing I commonly get is when it comes to, I'm looking at the camera, when it comes to pain management, doctors, we have it all wrong. Or healthcare providers, we have it all wrong. Because many people really complain that we don't really address their pains.
Yeah.
So how has that been? How was your interaction with the healthcare system? You can be nice a bit.
Oh, okay, I should be nice.
No. Just be honest.
I mean, as I said from the beginning, like when I started going to hospitals and stuff, I would be dismissed, especially by doctors, because it's like, you're here because of your period, you know. And it's one thing when you hear it from other people. It's different when you're hearing it from a doctor, because now you start really feeling like, anyway, I'm making this up or I'm exaggerating. It's not that serious. So I heard that so many times with, like, because I had, quite a number of visits before. So is that gaslighting? I think that was gaslighting. Yeah,
they would say it is.
Yeah,
you're not actually judge.
That was you know. So yeah, it's just like, it's not that serious. And then now, this one, just before I got my diagnosis, he just associates and just said, okay, PCOS, and I was just like, okay. Me, I'm hearing from a doctor, so I take it.
Yeah.
So there's been either there's being dismissed, even nurses, you know.
Okay. You cleared the
yeah, because you'll feel, even just from the way they treat you when you're when you're seeking treatment. And I remember, like, when I'd have to get like the drip, you know, and I think the first time, or this last time before now, I got the endometriosis diagnosis, and I'm like, why are you giving me paracetamol? Because by the time I'm coming here, do you think I've not taken paracetamol? Like, do you think I'm here because I think I've tried everything else? So, like, what, you know, and then you go through the first one and the second one and the third one, and none of them are working. But and then it's just like, again, una overdo. You know, that's the attitude that I'd get. That, you know, that I'm exaggerating. So it took a while before I even had faith in in the healthcare system, unfortunately. Yeah, but I'd say the gynecologist that I met now and then, who even now performed the laparoscopy on me, has been so gentle. It's I was like, wow, hapa ni wapi? Wow. You know, because from just from the beginning, there's not one time that I've gone and he's been like, yeah, you're overdoing, or I think maybe because now maybe he's an endo specialist and he has seen, you know, he's seen how these things manifest and such. So let me say, I've experienced both extremes. I've experienced the dismissal, and I've experienced those who are gentle and actually listen. And the difference is huge, and the impact that has.
You know, funny enough, you've said that. Because I had a sickle cell warrior. So we also have an episode on sickle cell. It should have come out by the time this episode goes out. Yeah. And she said the exact same thing. Yeah. Like, it's like we start from the lowest of pain medication. Even after asking, so on a scale of 1 to 10, where is your pain? And then you start from like quite a low place instead of like high. And many times you find people who are living with, I don't say chronic conditions, but conditions that you manage over time. Yeah. It's like you reach a point where you know, this is what works for me. Yep. But she said that sometimes it's like they feel that now you just want another hit. Like you're almost a drug addict. Because like sickle cell, the crisis can be very painful and they ask for morphine. Yeah, so sorry about that.
Yeah, I'm going to agree with her. In all honesty, like, and I see it when a patient comes to me with endo, they're almost not sure I'm going to believe them. And that's so sad, you get, because they've not been believed so many times. So they'll be like, I usually get very painful periods, and I promise you, I feel like I'm going to faint when that happens. And I'm like, I believe you, like, it's your body. You're the
Yeah.
one who knows how bad that pain is, but the fact that they're going above and beyond to convince you that truly this pain is so excruciating means that somebody somewhere did not believe them a number of times.
That's true.
And okay, for me, I feel like in terms of pain, especially because I do a lot of surgery, I tend to
Yeah.
overtreat, and I've had that from people. But I'm fine with that. I'm fine with that. I'm those people who come with like the bazooka of pain medications fast, then de-escalate,
Yes.
which is not actually the right way. The right way is to go from the lowest to the highest. But you are completely right. There are people who have just like excruciating pain, and those are endo people, sicklers, people with cancer, like their pain is not for sure for Panadol. It is not that kind of pain. And yes, they do know actually at some point what they require. But and at the same time, I'm still gonna insist we have to believe their pain scales.
Yeah.
We have to believe their pain. If they say it's 10, it's if they say it's 20, it's
Yeah.
20. It's not like how can it be 20? Like,
Yeah.
or are you sure it's not like a 2? So that's one of the things. And I think the experiences, as you've mentioned, are usually so different. First, because maybe just the amount of knowledge that different people have, you get and this is not to belittle anyone, but if you're gonna meet a clinical officer, a nurse, a medical intern, a gynecologist, and then an endo specialist, it's gonna be a completely different set of empathy, a different set of care, a different everything that you're going to experience. And I'm not saying that everybody should access an endo specialist. Sometimes the diagnosis has to be made first, and sometimes you don't even have access to that. But I think also knowing that, and knowing that, there's a high likelihood that if I see this person, maybe my pain may not be attended to in the way that I want. I think it's also important to know, so that you can also seek a second opinion, a third, and yeah, I think that's important as well.
And that thing I'm always for the opinion. Please, second opinion, third, fourth.
Yeah,
If
me
you
too.
must,
Me
if you
too.
must,
Me too,
don't
yeah.
feel stuck with someone or a provider and you're feeling like you're not making any progress.
And also, if you seek a second and third opinion, and then the three opinions are aligned, and you feel like you want to go back to the first opinion,
It's
that's
fine.
also okay.
Yeah, it's fine. It's actually fine. Oh, that's interesting. So you overtreat. Hey, me, I'm here for it. Let me tell you.
With pain, yes.
Me and pain. And the thing is, I think as a doctor, sometimes you can't relate, especially if you've never gone through that. So when I came to relate is when I injured my foot. When the nurse asked me on a scale of 1 to 10, where is your pain? So me, I'm there. I don't know. I was trying to be, like, it's not that much. I said 4. My sister was just like, stop lying. She's like, that can't be a 4. And I think I would say it was an 8. But I realized if I don't know how to like rate the scale, how can a patient also rate the scale? So sometimes just be like, honestly, just believe them. Because it's their reality. It's their lived reality. Yeah. Then you talked about now your management and some of the side effects of the treatment. And I just wanted to find out from Doc, like apart from surgery, what are some of the other modalities of care that are there for endometriosis?
Well, there's a number of things, yeah. So the definitive diagnosis, as we mentioned, is laparoscopy.
Yeah.
That being said, we do have endo specialists who can do a really good vaginal scan and tell you that, what, this is mild, or this is stage 1 or 2, this is not too bad. And not everyone is actually gonna jump into surgery. Some people are not ready mentally, some people are not ready financially, and we have to find other ways of dealing with it. Not everybody's gonna, and some people just hear surgery and want to run, and I do understand those people as well. Yeah. So we have to find other modalities of how to manage it. First of all, I think for me the most important thing in terms of management is for patients to understand that the nature of endo is that it's worsened by estrogen production. Estrogen production is actually what makes endo happen. And even for us to understand what endo is, for those who like don't understand it, it's basically tissues that resemble the lining of the uterus being found in locations outside the uterus, right? So we have the lining of the uterus, which sheds every month as your period. And that continues to happen in endo, people who have endo. But now what happens with endometriosis is this lining or tissues that resemble that lining are now found outside the uterus. So they can be in the ovary, the bladder, the rectum, any organ, the liver, the diaphragm, the lungs, the brain even, And those are the women who actually convulse every month when they have a period because they have a lesion in their brain that is endometriosis. So it can be any, I think the only place it can be is maybe your nails, hair, bones, things like that.
Like TB or something?
Exactly. Those tissues that, can't really get endo, right? And so what happens is that it has the shedding of itself, just in simpler terms, that continues in the new location. So it's secreting itself in the new location. So if it's on your ovary, it's doing that micro shedding there. It's doing it in the bladder, it's doing it in the rectum, and that causes a lot of pain, a lot of inflammation. And when that process ends at the end of that cycle, in the healing and scarring process, it can form an adhesion. So basically a tissue that makes that organ where it happened stuck to a different organ. So if it happened in your ovary, the ovary can get stuck to the tube, to the side of the uterus, to just the side of the pelvis, or anything around it. And that's what an adhesion generally is. And generally, organs are supposed to move freely in the abdomen. They're supposed to move freely. So when you tag an organ and it cannot move anymore, so not only is it having endo in it, but it's stuck, that hurts as well. And so the inflammatory process, the adhesion, and the actual endo itself is what causes all of that pain. And the very interesting fact about endometriosis, and this is like for me the biggest thing that I usually tell people, the size of the lesion never corresponds to the pain that you feel. You can have a 1 millimeter endo lesion that causes excruciating pain, and you can have a 5 centimeter patch of endo that you didn't know about until you did a scan. So the size does not correspond to the pain, because people always feel if it's excruciating, I must have endo everywhere. And it's not like that. Sometimes the lesion is tiny, but the pain is out of this world. And I think that's important to know. So when you do the scan and you have like mild or moderate endo, there are some people who actually say, you know what, we're not going to do surgery, because with the nature of this disease, the fact that estrogen triggers it, it could advance. So if we do a surgery right now, there's a chance that we might have to do a second, third, fourth, fifth surgery. So sometimes it's a balance of, is now a good time for surgery? You know, or do we try something else, see how it goes, and then do surgery at a later date? And also we want your surgery sometimes to align with the time at which you're looking to get pregnant. Because when we do the surgery and we remove all the lesions of the endometriosis, 3 to 6 months later is a really optimum time for conception, because we removed most of the endo, the pelvis is fairly healthy, so to speak. It's a good time for conception. If you're not looking to get pregnant anytime soon and we do the surgery and it comes back, you're looking at 2 to 3 surgeries even before you are ready for having kids, you know, if at all you were thinking about having kids. So the timing of the surgery also matters. But to answer your question, what is it that is available outside surgery? We do have hormonal medication. So because it happens with estrogen, we do have progesterone-based medication, which is the counter hormone, so to speak, for estrogen, that helps the endo to shrink, or at least helps to manage the secretion of the endo lesions. And, you know, they can get smaller or at least less painful. We're just trying to manage the situation. So you can take that orally. You can take that in form of an IUD. So the hormonal IUD, it's called, well, some of the brands that are available are Mirena, you know, Kylina. Those are used sometimes to manage that, because we're providing progesterone. And what the hormonal IUD does is that we're putting progesterone directly into the uterus and its surroundings, which is where majority of the lesions are, to either stop their growth, slow down their growth, or shrink their growth. It manages the pain. Works for some people, doesn't work for others, works for some people for some periods of time, and then at some point stops working, depending on the amount of progesterone or the extension of the lesions. If they grow worse with the IUD, then of course the pain will not be managed as well. Of course, depends on what organ was being affected in the first place. So that's one of the options, the hormonal IUD, the oral progesterone. We also have GnRH antagonists and agonists, which we can use. Some are oral, some come as I'm going to call it a little stick that you put under your skin. So it's inserted under the skin and it releases tiny amounts of hormone for a particular amount of time, 3 months, 1 month, 6 months, whichever you like. And what it does is that it causes, I'm going to call it artificial menopause. So we shut down your ovary and we stop it from producing what it was producing that helps the endo to grow. And so with that, unfortunately, now symptoms, hot flashes, mood changes, insomnia, back pain, bone pain, water retention. So sometimes it's a balance. What do we go for? Do we, especially, and also with your age, because if you're 25 and I'm going to shut down your ovary and put you in artificial menopause, as a doctor, I really need to think about, is this the right way to go? Do I instead put a coil? Do I take you for surgery? So those are some of the things that are available. We also have, other things like nerve blocks. We can literally have an anesthetist just block the nerves in your pelvis and see whether that helps. And then, of course, there's new areas of research that people are going to, things like exosomes. There's also, which is one of my favorite. It's and I hope like it makes a really big difference in endo. It still hasn't, and there's a lot of research to be done. But we have something called high intensity focused ultrasound treatment. It's called HIFU, and right now we're using the same treatment. So I'm incidentally a HIFU specialist,
Oh, look at
recently
you.
trained. Yes, there's just a number of us in Kenya. I think we're about 5.
Is that what you went to China for?
Yes.
You
Yes.
see, I keep track.
Yeah, thank you. So I am a HIFU specialist, and right
Okay.
now we are using HIFU to treat adenomyosis. So basically, we're taking high intensity ultrasound sound waves, converting them into heat energy to burn off the adenomyosis. And adenomyosis is a sister disease of endo. So it's exactly like endo,
Yeah.
except you have these tissues resembling the lining of the uterus, penetrating the muscles of the uterus, but not going out of the uterus. That's what we call adeno. And they shed themselves every day in the muscles. So every month you're having microbleeds into your muscles. And that's very painful. So if ultrasound energy can be used to burn adeno, we're trying to discover, can we also use it to burn endo? A bit more difficult because if I burn your bladder, if the endo is in your bladder, we're not gonna be, having that kind of conversation.
Yeah.
It's safer inside the uterus because it hasn't gone out of the uterus, and that's why we're using it for fibroids and for adeno. But we are trying to make, progress in terms of research. Like, can we actually use this for endo going forward? And if it makes progress, it's gonna be fantastic because now it's non-surgical
lovely.
treatment. Yeah.
So please, the funders of women's health research, we are really waiting for you guys. We need these things to actually work.
We do.
Yeah, we
Oh,
do.
wow,
And of
that's
course, we do have
interesting.
also non-medical,
Yeah.
so to speak, lifestyle changes.
I'm sure, Vanessa, you'll tell us about
I
your
think
experience.
she probably is better at this than I am.
But you've mentioned actually something about the artificial menopause or the
Right.
medically induced menopause.
Right.
So I actually was listening to some young girl's story, her endometriosis story, and her started just like yours. She was very young, and she reached stage 4 by the time she was, I think, 20. She'd had surgery, it came back. And then when it came back now, they found out that she also has adenomyosis. So now that's like double,
Yeah.
So they try to treat now the endometriosis with now the medically induced menopause.
Yeah,
And that time she's
GnRH,
22. So she had all the symptoms. So she was just like, I'm a 22-year-old. I'm having
I'm
hot
in
flashes.
menopause,
My mood is
yeah.
off. My bones are brittle.
Yeah.
And by the time she was under 25, she'd actually had a hysterectomy.
Yeah, that
Because
can happen.
there was nothing else that she could do. And now she has 2. It was adeno and endometriosis. And I was just like, wow, yeah, we need advanced research to just like,
sure.
We really
hurry up
do.
and come and save us.
Yeah.
So now, Vanessa, apart from the medical treatments,
Yeah.
what has been your experience, especially with the lifestyle changes? Because they also contribute to the management.
Yeah. I think for me, I had to just monitor and see what were my triggers, like what would make the pain worse. And I noticed there's some certain types of foods that I would have that would make it, a bit more intense. So I'd say even things like carbonated drinks, like sodas and stuff, and then I
So
get
you
a
had to
bit
cut off
bloated.
soda.
Okay, I've not cut it off, kabisa, but I've reduced intake because I used to be like it used to be quite a lot for me. So
Yeah.
I'd noticed like when I have a lot, I don't know, like
It becomes worse.
yeah.
Maybe it's the bloating.
I think
the
it is the bloating.
Yeah.
Yeah, it is the bloating. For me, caffeine as well. And that was a bit sad because I really
You're a
love
coffee.
coffee.
Hey, I think the people who are dependent on coffee.
No, I mean I'm not
It's an
dependent.
addiction.
Yeah, I mean I was not dependent, but
Yeah.
I love it.
Yeah.
But I was like, okay, now I mean I love it, but then I'm here suffering after. So had to cut that out as well.
Yeah.
And then okay, again for me, I'd also notice like red meat, especially if I have quite a lot, it would also, affect. And it's all the things I love, to be honest.
Yeah, that's what I'm hearing.
So it's just like, oh Lord. So I just reduced the intake. Yeah, I mean, like I'll have it like once in a while. So I just reduced the intake. Then of course increasing your veggies and stuff. I think foods high in fiber.
Yeah.
They would help. And then I think, is it anti-inflammatory?
Inflammation is a word that you can question,
Yeah.
not to take away anything from you. Doc, do you find the word inflammation is misused
Um,
or overused?
overused.
Overused. Okay,
Yeah.
overused.
Inflammation.
Yeah.
First of all, inflammation is on a cellular level. So how do you even know you have it?
That's true. Yeah.
Yeah.
Mhm.
Yeah. So, I mean, I try and take those a bit more.
Yeah.
I wouldn't say that I've felt like they've improved,
Mm.
but maybe something's also mental.
You're willing to give it a try?
I'm willing to give
That's
it a
true. Now,
try.
before we
So
get to the
just-
mental part,
Yeah.
I have a question, and I'm asking from a point of ignorance.
Mhm.
For endometriosis, is the pain only during your periods, or does it come even outside your periods?
Can come even outside your
Outside.
periods. Yeah.
Okay.
Yeah.
The majority of it is dysmenorrhea, which is pain during your periods, but some people have intermenstrual pain. Some people have chronic pelvic pain.
Yeah.
If I tag your ovary
Okay.
to your
Yeah.
rectum,
Mm.
you will be in pain. You'll be pain every time you pass stool.
Yeah.
You could be having pain every time you have sex, especially if you have endo in the vagina, or if your uterus is completely adherent to the structures around it, meaning your uterus can't move freely even during sex. You'll have a lot of pain during sex. So it's not just period pain,
Okay.
for sure. Yeah.
Okay. So thanks for elaborating that.
Yeah.
So now I know there's a lot. It affects your mental health a lot.
for sure.
So how
For
did you
sure.
navigate that?
I am still navigating it. Because I'd say for me, like every time I have a flare up, I think I go into panic mode, like almost immediately, because I'm like, is it back? Am I going to? Because okay, let me just mention from the treatment options Doc mentioned, I got the Mirena coil, so it's suppressed, so I don't get my menses, but I still have flare up sometimes. But so yeah, anytime even kidogo pain, I just feel something. And I'm like, oh snap. Yeah. And it has increased my anxiety, I won't lie. So it's just trying to manage that.
Find a way to just manage it.
Yeah, do like this. I
Do
tell
like
myself,
this.
do like this.
Do like this. Do like this. It's okay.
It's okay. It's
Bas,
okay. Bas, exactly. So I've had to really also just talk to myself and you've got this. And then there's the thing of how will I perform at work as well, because I think for me, Kwanzaa, I went into like hyper performance after the surgery and all that, and then I've come back and I'm like, okay, I don't want these people to see me as weak and like I can't do things, so I'm overdoing. And now that overdoing is just, it was it's making it worse, those kind of things. So it's like there's a lot. And then there's the thing for, first of all, also people not just really believing your pain. And even with, sometimes even when you're hanging out with friends and you're in pain and they're like, oh, Amma, you can't hang out with friends because you're in pain. And they're like, they don't get it. People really don't get it. I'm just like,
she's always in pain. Like,
Yeah.
she's always,
Yeah. Oh yeah, and then another thing I forgot to mention, but to tie into this was like in the lifestyle changes, I had to cut down my intake of alcohol. Yeah, because for me, I also noticed the pattern on how it affects. And then now it's like, again, maybe you're hanging out with some people and it's just like, yeah, this is a party pooper, those kind of things. It's like, why won't you just drink? So you just drink. And I'm like,
in fact, Kenyans need to stop that habit.
please.
We just need to cut it. No means no. Like,
no means no. Like stacky, so much stacky.
Yeah.
However, you're like, oh, you're not drinking because of your endo. Like, itaisha too,
That's actually quite rude.
It's like, it's me who will suffer. Me, I know myself,
Exactly.
and I know my
Exactly.
experience. So please, believe me. And then it's also that thing for like, I hate having to explain. It's just like, okay, how many times am I going to say this thing? And then there's also, hey, let me tell you, everyone has an opinion on how you should do things.
Unsolicited advice.
Everyone will tell you. And then I think the one that shook me the most was, and I heard this from a medic, and and they're like, just get pregnant.
I've had people say that even with PCOS.
Yeah.
Like, yeah, just get pregnant.
Well, I'll get back to that in a moment. In a moment.
Yeah.
I was hoping Vanessa could tell us about because she said that the triggers,
Yeah.
she could also tell us about the things that actually make it better.
Better.
Yeah. Because there are
Yeah.
some things that are non-medical
Yeah.
that make it better.
Yeah.
And that will really,
Yeah.
help some people.
someone. Yeah.
Okay, for me, I usually walk around with a heat patch. You know those ones for the
The
deep
deep
heat
heat
ones,
ones.
because I think there is a way that heat just soothes. So thank God for it, because then I don't have to walk around with a hot water bottle. But so that really helps me. Hibiscus tea also, I've noticed that actually helps me as well. Okay, there's exercise. But then now exercise that I've had to learn how to also balance, because when you overdo, you will trigger
getting pain.
Yeah, and but again, you just can't stay dormant.
Yeah.
So it's just like, okay, so what do I do? So it's just trying to get like a that sweet spot, or like a good balance, so you're not overdoing and you're also not just dormant, so that it at least also helps. And I also had was doing a lot of like pelvic floor exercises. The gynecologist, or my gynecologist, had recommended Pilates. I haven't done it yet, but
All the best.
yeah.
Hey,
Yeah.
your leg is like
Yeah, but they did recommend Pilates as
Yeah.
well. So those are some of the things that
What
I've seen
about
how.
stress management?
Stress management,
For stress management, honestly,
Cinnamon.
Yeah.
but I
find
think
like that's such a crazy thing to tell adults, like manage your stress.
managers,
I'm like,
it's
how?
like there's
Yeah.
stress
How?
everywhere.
How in this country? How in this economy? How in
Exactly.
adulthood? How do you
How
want me
in
to
this
manage?
life?
It's
Yeah,
like
how do you want
everywhere
me-
you turn,
What do you
there's
want me
just
to
something.
do?
Yeah.
Exactly. Yeah.
Yeah.
But I've had to it's like trying to have a strong mindset, because again, that's another thing. Stress is a trigger, and
It is.
sometimes it's almost instant with the pain.
Oh,
Yeah.
okay.
It's like I'm stressed. There it
Yeah.
is. So I've had to tell myself, do like this.
Do like
Just-
this?
Yeah, do like this. Just calm down,
Yeah.
try and relax. So I get into a stressful situation, and I just really try and
Take it slow.
try and take it slow. That's a bit again something that you need to learn how to balance again, because that's taking it slow got to a point I just became very numb, because now you don't want to feel things, or because you feel like my stress, and then it's just now you detach from everything, and then I was like, okay, come back a bit. You
There's a
feel
balance.
you have to get that balance. And so I think every day it's just learning, like
I'm also gonna say with pain and stress levels, endo patients, and this is research proven, their perception of pain changes completely. So some become almost numb to pain, like their pain threshold goes through the roof. You could be doing stuff to them, and because they're so used to excruciating pain, they're like, whatever, because they're used to very high amounts of pain. And for some, their pain threshold goes really, really low. So now the smallest thing, they are in the most amount of pain. So mentally and pain perception wise, it's known that endometriosis changes your perception of pain, which is really crazy, because the way you are mentioning about the anxiety, because you don't know what you're going to expect. Is it going to be the crazy kind today? Is it going to be the mild kind? And so that also messes up with your mental state at that point. So that's something that I have to add, that it's very difficult to manage that, because you're not even a person who perceives pain in the regular way that people perceive pain. You could be perceiving it in a very high level because you're always used to that, or on a low level because now you've gotten into so much pain that even the smallest thing right now is painful. But about the pregnancy issue, so it's actually not a myth.
Okay.
It's actually not a myth. That's the funniest part about it. I call it the most expensive treatment for endometriosis in the world. So remember, first we mentioned that endo can cause fertility issues, can cause significant fertility, and I'll let you know how it does that. But the fact that it can be a struggle doesn't mean that everyone who gets endo can get pregnant. You can have endo and get pregnant, because there's different stages, But what happens is, remember we mentioned that this is an estrogen problem, yeah? Estrogen really makes endo grow. And so progesterone is the counter hormone to that. And during pregnancy, you produce insane amounts of progesterone. And so for some people, it gets their lesions to shrink or at least to disappear. And during the time that you're having a pregnancy, it's basically almost your body treating itself with high dose progesterone. Instead of me giving you that tablet of progesterone, now your body is producing it. You know, placenta is you're producing high doses of progesterone. And so if your lesions shrink completely or they disappear, and remember, it's 10 months, of high dose progesterone. And then afterwards, if your lesions shrink or they disappear, that's the reason why after delivery, you're probably not necessarily in that kind of pain. After you've had a baby, your body treated itself. You know, not everyone. Some women will have a pregnancy and they'll still get new endo or a recurrence of the endo, or they'll still have, but majority of women, if they get pregnant and deliver, they have had 10 months of high dose progesterone, which will now kind of make the symptoms better. So it's not completely a myth. Yeah.
Now I know what to
I'm
do.
still learning here. I'm in my notebook.
Yeah.
Yeah, I love doing this because I'm always learning. Like every guest who comes, I'm just like, oh, okay, I've learned something today. Now, because I know we can talk for ages.
Yeah.
Now, just to wrap it up, maybe Doc, you can just tell us the stages, because I keep hearing stages of endometriosis. And for Vanessa, maybe you can tell us something that you'd like people to know about endometriosis, or just living with endometriosis. You said it's not a life sentence. Like you're capable and very able and resilient to that. Go ahead.
Oh, I start?
Yes.
Oh, okay. I think what I'd say to people who, especially, you know someone who has endometriosis, or you know someone who has abnormal period pain, please believe them. Believe them. And then I'd also just like treat someone with some empathy. Because I also, God, there are some comments that you receive and it's just like, oh my Lord. And just believe that imagine I'm not weak and or I'm not overdoing this. And if I tell you maybe I can't do this, a certain thing, I can't show up and such, just at least please understand, because there's a lot of that. Or maybe I could just mention a bit. It's like it for me, it's been a bit difficult even now, just trying to see how to navigate relationships, because it's just like it's like, will this person understand? Will they
empathetic?
Will they be empathetic? Because I have met those who have not been empathetic and very dismissive and all that. So it also becomes almost like you're even afraid of just starting this new thing, with someone. So, hey guys, please just be empathy is the thing, I think I would say. And it's not like you treat me like an egg, but
but treat me like an egg.
Yeah, but treat me like an egg still. Like I'm just a girl, a baby, But I think I'd say empathy, and just the way you were saying, when it comes to medical research, I just really wish like a lot more could go into this, because we say if this was a man's disease, we would have
a solution by now. I
we would
think.
definitely have a solution by now. You can't tell me there's no definitive cure. Everything is trial and error and guessing and dream. So I just wish if we could get like more research and more funding that goes into this. That would be that would be great. That would be fantastic. But and to any endo warrior out there, you've got this. You've really got this.
And actually, she's wearing yellow for endometriosis.
I'm wearing yellow because
I was thinking how I had planned to wear yellow, and then it's like in the morning I just forgot. And then I did share she's in yellow. I'm like, so please just accept my gold.
It still works, don't worry. And I took one for the team.
Thank you for that.
So to any endo warrior, you've got this. You can really live like a normal lifestyle with some adjustments, but it's all good.
Doc, I'll just add another layer to your question. Maybe how can we make accommodative workspaces for ladies who are going through endometriosis management and just living with endometriosis?
Yeah. So in terms of the workspaces, It's very difficult for me to say that because it depends on the employer,
Yeah.
whether it's government or private. And it depends on, how strongly your employer believes in actually making a conducive work environment for a woman who has endo or any other menstrual issue or any other reproductive health issue.
Yeah.
Some companies are really going out of their way, not to like promote any other company, but like ABL has specific days for menopause symptoms, yes,
Oh.
that you get off,
Okay,
and that's
that's
like a big deal,
nice.
yeah. And there are some African countries that are now saying that, look, in a year you're gonna have to give a woman at least 3 days to be able to take just for menstrual issues, and that's amazing. Those are some of the things that people can do, as a country. But as a private employer, at the end of the day, you're the alpha and you're the omega. Your word goes. If you say there'll be nothing, I'll give you guys. People either take the employment or they don't.
Yeah.
But it would be good to have some days off. It would be good to have some compassion. It would be good to have maybe even just in the environment a room with a heat patch, a hot water bottle. Sorry, what are they called? They called silence pods or something like that.
Oh wow! Like the
No,
like
I
a thing you
can't
just
sing.
enter and it's just sorry. Do you want a
Silence.
glass of water?
Yes, please.
Oh
I
yeah, please
choked.
get one. Hey, before we lose someone here, please.
No. But yeah, some people have sensory pods where you enter and just like you're sensory deprived, silence, no lights and all
Yeah.
that. That sometimes helps women with endo. Also, people in the work environment just understanding certain conversations. Like if I have endo, please don't just like be throwing around fertility conversations. It might be a trigger for me,
Yeah.
just for people to be more aware in the space, more understanding.
Thank
you.
Sorry.
Choked on my own saliva.
Sorry.
Yeah,
Feel free to put it there. Yes, you can.
So yeah, days of just a little modification of the environment. Not everyone can have a sensory pod at work, but you can have a dark room where I can have 30 minutes to myself if I'm in pain. If I'm a boss, like have places that have, sanitary products, just a bit more empathy and understanding. Maybe also educate the male staff, and then also have some understanding in terms of productivity. If I'm in the middle of my menstruation and I have endo, I'm not going to be productive. Please just understand. Let's have a discussion. Let me see how I can compensate for my productivity on other days, right? I'm not saying I'm here to be useless and not produce and not give output. I will. I just can't do it like a man.
Yeah.
And I can't do it on every day.
Yeah.
So I think things like that could really go a long way. Also for insurance companies, there's a lot of stuff they're not covering for endo, and that's kind of crazy. And I'm gonna like call them out. Like you
The
cannot
floor is
call
yours.
this, a chronic condition. You cannot say, what do they call them? This word that irritates me. Diagnosis of exclusion. No, like that's not gonna be acceptable anymore. Like endo is serious.
Yeah.
If you can cover cancer, you can cover endo. Just because it's related to a period doesn't mean that now you start minimizing it and twisting around things, and just like even just getting insurance to be able to cover certain things in certain countries and certain insurance companies and certain places is becoming more and more difficult, and that's ridiculous. So those are the modifications outside medicine that I think that we really need to take very seriously. Yeah. In terms of the stages of endo, it's more of a medical thing. It's kind of like for
Okay.
a doctor to know. We have stage 1 to stage 4, stage 1 being mild, stage 4 being the most severe. But basically for regular, information is what needs to understand is sometimes you just have lesions on the surface of certain organs. Sometimes they go really deep into the organs, and that causes, of course, more pain. And sometimes your organs can get stuck to one another, which causes the most amount of pain. So stage 4 is where you have a lot of organs stuck to each other, big patches of endo, deep infiltration into organs. We call it deep infiltrating endometriosis. That's basically stage 4. So for a patient, it's in terms of the amount of pain you're going to experience and the also the damage that the endo is going to do to your organs. So the fertility issues come about by endo blocking tubes, changing your hormonal status, changing whether you're able to ovulate or not, damaging your ovary. But also when we come into the surgery in terms of stages, if you're at a high stage, you could lose a tube, you could lose an ovary, you could lose your entire uterus, especially if it's very severe stages. So one thing I need people to remember is pain is not equal to the stage, but at the same time, if your doctor tells you, look, you had stage 3 or stage 4 and I had to do away with your tube because if I left it, you could get an ectopic pregnancy, then that's something you also need to understand. Nobody wants to take out a tube. I can tell you there's no guy now who wants to take out a tube. But by the time the endo is so bad and I'm putting you at risk of another condition, yeah, I'm going to take out your tube to make things better for you long term. So the stages are basically for people to understand how complex is my surgery going to be, how deep has this gone, and what am I likely to lose? Yeah.
Thank you so much for that.
welcome.
Now, Yakufunga, I promise. I promise.
No
When I was doing my research, because I think, Doc, maybe you can agree with me, in undergrad, we didn't like go into the
No,
detail of
for
these conditions.
sure.
So I'm also learning myself. And I had this remission in endometriosis. Do you mind touching a bit on that?
Remission is a really tricky thing in
Okay.
endometriosis. So some people, first of all, there is lack of clarity even about amongst clinicians as to what are we going to call remission per se. You know, sometimes people say, I've had a surgery. A lot of the endo has been, I'm going to call it debunked, because people are starting to equate endo to cancer. It doesn't kill you,
Yeah.
but the way it spreads, how it devours your organs, so to speak, people are starting to equate it to cancer.
Okay.
But so in terms of remission, when you've had a surgery and a lot of the endo has been removed, a lot of pieces have been, the ones that are accessible, have been removed. And then afterwards, we're going to say, we're going to put you on hormonal treatment. So we're going to give you an option of having the hormonal IUD so that it can shrink the little that maybe we couldn't access or couldn't see with the naked eye, because we do have a microscopic entity of endo as well. So the hormonal medication after surgery is gonna take care of that. Yeah, we could put you on oral, we could put you on hormonal, we could put you on the GnRH, depending on how bad we think it is. Yeah, and then for a while after that, you're not really having symptoms per se.
Oh.
Is there real remission of endo? That's tricky. We've had patients who are like 5 years post surgery with a hormonal treatment that are fairly comfortable symptom wise. And then all of a sudden it's back again. So in that 5-year period, could you have called it remission? I find that a very great term. I find that it confuses patients because when I tell you remission, I've given you hope. And then when it's back, you're like, well, I thought you said remission.
Yeah.
So it's a very difficult thing in terms of just the patient understanding what remission looks like. But yes, we can call it a time when you've had certain procedures or interventions and your pain levels are much more controlled and you're much more comfortable. As to how long that lasts, very debatable.
Okay. Thank you so much for that. So I usually end with your dose of health for the day. Just keep it short and brief. I think, Vanessa, you said yours. No, you haven't said. You've given your parting shot, but a dose of health, like something you want people to learn or to adopt. Dose of health for the day.
With regard to endo as well. Hey, you're putting me on the spot. I'd say listen to your body. Yeah, just listen to your body. You will know when something is off.
Okay.
Yeah, even with all the, can I say, gaslighting and stuff, you will still know. Yeah, when just listen to your body, basically. Yeah.
Doc, over to you.
I struggle with that question. So many things. I have like 100.
Just pick
But
one.
one thing that's completely unrelated to endo is I'm going to tell women you deserve good sexual health. I feel like that's minimized a lot of times, and we've been kind of conditioned that our sexual experiences are tailored for our partner and not necessarily for us. And I'm gonna tell women you deserve good sexual health and you deserve intimate wellness, and you should demand for it. Yeah.
So you now me do even go next. I think for me, I would say I'm that person who says manage your stress, but because you've been told now it's very hard, find good coping mechanisms. Yeah, that's what I would say. Yeah, just find good coping mechanisms to try and navigate your stressors. Yeah. So now, guys, do you want to be found on the internet?
Yes.
Oh, yeah.
Okay, so this is your moment. Plug yourself and then we'll close.
All right. So for my personal pages, that's Wanjiko_Kanyaru. That's on Instagram, on TikTok, on YouTube as well. And then for my podcast, it's Oh My Mind, Podcast KE. Again, on Instagram, on TikTok. Yeah.
We'll put them,
That's
don't
it.
worry.
Yeah, please. So, yeah.
For me, my Instagram handle is Dr. Christina_Sule. Same on TikTok. I have a YouTube channel called Your Free Consult.
I'm learning
Yes.
things. Okay.
I'm not very active on it because it demands a lot of my time, but it has a lot of really great episodes. My clinic page is called Alora Medical Practice. That's on Instagram, on Facebook, and on TikTok. I also have a luxury postpartum retreat, the first in Africa, where we take care of women who've just given birth and we give them luxury conditions. We give them a private chef. We give them 96-hour nursing. We give them, massages, pedicures. We have all your doctors come to you in a luxury environment, which is in a hotel actually. And so this retreat is called Uko Postpartum Retreat. And you can find us also on Instagram and on TikTok.
How do you manage all those pages? Where? But thank you so much, guys, for coming. Don't worry, we'll put all your handles. They will find you even in the description. They'll be in the description, so you can't see Atumekosa. My name is Dr. Hope Simiu. On Instagram, on TikTok, there's some hyphens, but don't worry, it'll be here. And then follow the podcast, like, subscribe, share, comment, please. And yeah, be sure to keep up with the other episodes, and hopefully we'll get to have more insightful conversations like this. And that's a wrap.
Thanks for having us.
Thank you.